Everyone, respected Emeritus Chairperson Sir, VC Sir, dignitaries, faculty members and dear students. The Department of Orthopedics is going to present a CCR today. So before we start the CCR, let me give you a brief overview of the functioning of the Orthopedics Department. So we have in the faculty 5 professors, 2 associate professors, 4 assistant professors and 3 senior residents. So each year we are taking PG residents, and this year our seats have increased to 12. So now we have 12 first year residents with us. So this is the distribution of faculty members in the 4 functional orthopedic units. We have 2 dedicated, well-equipped modular orthopedics operation theatres. The patients coming to our OPD is steadily increasing. So last year we had around 43,000 OPD patients. Similarly, we did our orthopedic surgery number of operations were over 1,500. We are doing all types of orthopedic surgeries, including replacements, arthroscopies and other trauma cases. There are few, these are post-op pictures of our patients. Simultaneous bilateral total hip replacement, unicompartmental knee replacement, reverse shoulder arthroplasty, simultaneous bilateral total knee replacement. We are also doing with a sizable number of pelvic and acetabular fracture cases. In fact, our center is one of the largest ones in Rajasthan dealing with pelvic acetabular fracture surgeries, and the patients have a very good functional outcome. We are also dealing with complex shoulder surgeries. We are doing all kinds of spine surgery as well, discectomy, fixations, decompressions, scoliosis correction surgery. We have foot and ankle surgery cases also, deformity corrections. We are doing shoulder arthroscopy, knee arthroscopy regularly. We are dealing with multiple ligament instability cases. We also have a good number of bone tumor cases, and over 100 limb salvage surgeries have been done. Of them, 12 were extracorporeal radiation therapy cases. We also did 5 vascularized fibula grafting cases in early cases of avascular necrosis of the hip post-COVID. This is the tabulation of the various surgeries that we are doing. We are steadily increasing number of arthroplasty cases and arthroscopy cases. We are regularly having morning PG seminars. We periodically have clinical simulation seminars, live surgery CMEs, bone saw model seminar, and we also had an inter-college ortho PG seminar at our center. We run orthopedic subspecialty clinics every day in our OPD. We have a good number of publications. 38 publications were in the PubMed Index journals and 56 publications in UGC Care List recognized journals. So with this, now we come to today's CCR presentation. This is a case, a 13-year-old female with hip pain.
Thank you, sir. Good morning to all the faculties, dignitaries present here, respected chairman, sir, and my dear colleagues. Today I, Dr. Shashank Rastogi, third-year orthopedics resident, here to discuss a case of a 13-year-old female with hip pain. We have a 13-year-old female student, resident of Jhunjhunu, presented with chief complaint of pain in left hip since 3 months and difficulty in walking since 1 month. The patient was asymptomatic until patient started experiencing pain in left hip region since 3 months, which was insidious in onset, throbbing in nature. The pain worsened from mild to severe over the course of 2 months. The pain was rapid in progression. It worsens by movement and partially relieved by taking analgesics prescribed from a local practitioner. This escalation in pain was so much that it coincided with a decline in the patient's ability to carry out daily living. The pain is associated with diurnal variation as it worsens by night. The patient did not have any history of significant trauma. There was no history of fever, loss of appetite and weight loss. There was no involvement of other joint and morning stiffness. To the patient, a 8th class student, occasionally took analgesics from a local practitioner. There is no significant past history. The patient follows a vegetarian diet and has no history of addiction. There is no significant family history. Patient got her first menses 1 year ago. To summarize, this is a 13-year-old female with a 3-month history of pain in left hip, which increased so much from mild to severe in intensity, so much that the patient was unable to do daily activities and increases during night. Before getting to possibilities, I would like to I would like to ask the audience, on basis of listening history, what are the possible etiologies in your mind? Anyone?
Based on the history, the possibilities could be of infective or inflammatory pathology.
And trauma.
Yes. First, we will think of an inflammatory etiology, then neoplastic, then it can be infective, then it can be developmental, then it can be traumatic. However, there is no history of trauma, but in pediatric age group, it is usually masked by either parents or children. The patient is moderately built, well nourished, and is conscious, alert, and cooperative. Vital signs including pulse, blood pressure, and respiratory rate are within the normal ranges. On further examining, there was no significant findings on general examination. Patient came to us with an antalgic gait. Here we have a video, however, it is not the actual video. It is just for demonstration purpose that how the patient came to us. Here we can see that the patient, to offload the pain, the patient is having less stance face and more swing face. On examination of the right hip, skin is normal, there is no swelling, scar or sinuses present. There was a visible flexion deformity of 10 degree at left hip. There was muscle wasting present at left mid thigh and calf. On palpation, temperature was normal compared to the other side. There was no superficial tenderness noted. Here there was deep tenderness present on the anterior joint line of left hip. Here it is a pictorial representation where we will palpate the anterior joint line. It is just below and lateral 1.5 centimeter to the mid-inguinal point. Further moving on to measurement, there was no true limb length discrepancy. On comparison with other side, both mid-thigh girth and calf girth was less than 3 centimeter and 2 centimeter respectively. Patient's range of motion, both active and passive, was globally restricted and painful at left hip. There was no neurovascular deficit of the left lower limb. Movement at other joints, right hip, bilateral, sacroiliac joint, knee and ankle joint were normal and pain-free. Rest other systemic examination, nothing was significant. To summarize, we have a 13-year-old female presenting with pain in left hip since 3 months, which progressed rapidly from mild to severe intensity. Over the past 3 months, the pain has worsened, now affecting daily activities. At examination, tenderness was noted over the anterior joint line of hip, flexion deformity of left hip. Additionally, there is an antalgic gait. So after learning about the history and examination of patient, we would like to explore more about these possibilities. Firstly, there is a possibility of an infective etiology like TB arthritis or septic arthritis. At this stage of assessment, there was observed throbbing pain and night pain, but there were no constitutional symptoms like fever, malaise and weight loss. It can be neoplastic, which can be benign or malignant. Age, adolescence age, night pain and so much rapid progression points to this etiology. It can be an inflammatory etiology. Usually in this age, it is juvenile idiopathic arthritis. Age, adolescence age points us to it. However, no multiple joint pain because it is a major manifestation in this. It cannot exclude 100% of the juvenile idiopathic arthritis. In developmental, we will observe slipped capital femoral epiphysis. AVN in this adolescence is known as Perthes disease. Adolescence age points us to it, and rapid progression rules out this. Trauma, we can ignore the trauma etiology as there was no significant trauma history. After examining and history taking, we would like to advise investigations. We will request for an X-ray pelvis with both hips. Here we see sclerosed lesions on the margin of acetabulum and subtle rarefaction lesions over the supralateral dome of acetabulum. Here we see that periacetabular region is involved, so we will like to examine it more by asking a spatial X-ray, that is Judith view. Here we can see subtle lytic lesions over the left periacetabular area, which is not very significant. So we will further ask for investigations. Here we can see in second marker we can see there is sclerosis over the acetabulum margin. Among the blood tests, we decided to get CBC, ESR, CRP along with RA factor and ANA. All parameters were within normal ranges. Only slight elevated ESR was noted. Since X-ray and labs are insignificant, it's difficult to come to a conclusion, so we requested MRI to narrow down the possibilities. Now I would like to invite Dr. Diksha Alhawat from Department of Radiodiagnosis to discuss about MRI.
Good morning everyone. I am Dr. Diksha Alhawat, second year PG resident from the Department of Radiodiagnosis, and I will be discussing the radiological investigations for this case. So the patient had initially presented with an outside MRI lumbosacral spine. They did not have the CD of the DICOM scan with them and had only presented with the films of this case. These films were of poor quality and showed motion blurring artifacts. However, on reviewing these films, we could observe areas of altered signal intensity in the left iliac bone and acetabulum of size 15 by 10.5 centimeters with a soft tissue component on the medial and lateral sides involving the left iliacus and gluteal muscle. These findings were likely suggestive of neoplastic etiology, and hence an image-guided biopsy was done and the core of the tissue was sent for histopathological examination. Now I would like to invite Dr. Aditya Mundra from the Department of Oncopathology to further discuss the case.
Thank you, Dr. Diksha. A very good morning to esteemed dignitary members, respected teachers and fellow residents. I am Dr. Aditya Mundra from the Department of Oncopathology, and I'll be discussing the pathological aspects of this particular case. So we received a true-cut biopsy from the left iliac bone, and the cores ranged from 0.5 to 0.8 centimeters. Microscopic examination revealed that there were tumor cells arranged predominantly in sheaths over here. High power examination revealed that these cells exhibited increased NC ratio. There was cytoplasmic vacuolation, which was probably due to glycogen accumulation, and there was a diagnostic clue over here, which is homoryte pseudorosettes. So homoryte pseudorosettes are basically eosinophilic filamentous material, and they are surrounded by tumor cells, and this is a diagnostic clue of neuroectodermal differentiation. Along with this, there were large areas of necrosis and there was increased mitotic activity. So considering all the forementioned features, we gave an impression of malignant small round blue cell tumor, possibly Ewing sarcoma. So to confirm our diagnosis, we performed a immunohistochemical examination. So while examining the same foci comprising of homoryte pseudorosettes, the tumor cells exhibited nuclear staining for NKX2.2 and membranous staining for CD99. There was a negative expression for synaptophysin and CD45, which excluded neuroendocrine tumors and lymphoproliferative disorders respectively. So summarizing our findings, there were sheets of small round blue cells. They exhibited increased NC ratio. They had clear cytoplasm, hypochromatic nuclei. There was presence of necrosis and increased mitotic activity, and there was presence of homoryte pseudorosettes. these cells exhibited positive expression for CD99 and NKX2.2 and negative expression for CD45 and synaptophysin. So a final diagnosis of Ewing sarcoma high grade was given.
I would thank Dr. Aditya for his inputs. Now we know with the help of pathology, it's a case of Ewing sarcoma. Now we have to rule out metastasis. We have to do workup. We get a HRCT thorax. It was normal. The bone scan was done. It showed only localized uptake present in left hemipelvis. No evidence of any lesion elsewhere in the body. Since tumor it is a high grade histologically as explained by pathology, and it involves muscles, iliopsoas and gluteus minimus after breaching the cortex of bone, so it should be extra compartmental, and it has no metastasis as done by HRCT thorax and bone scan. So here we will put our sarcoma in stage 2B. Now coming on to final diagnosis. So we have a 13-year-old female with pain in left hip since 3 months, diagnosed as Ewing sarcoma of left hemipelvis, stage 2B, MSTS. The case was discussed in multidisciplinary tumor board with the following team. The plan of action was decided to start with neoadjuvant chemotherapy, then local treatment, then adjuvant chemotherapy. Case was referred to medical oncology for neoadjuvant chemotherapy. Now I would like to invite Dr. Priyanka from medical oncology.
Thank you, Dr. Shashank. A very good morning to all. As per decision of the multidisciplinary tumor board, the patient was advised for neoadjuvant chemotherapy. So the rationale for neoadjuvant chemotherapy was to control micrometastasis, as Ewing sarcoma is considered a systemic disease with very high chances of metastasizing to lungs and other bones. The second rationale being to avoid amputation and making the patient amenable for limb-sparing surgeries. The second rationale was not valid in this particular patient, as the primary lesion here was as it is involving the axial skeleton and not the extremities. The chemotherapeutic agents used in this particular regimen had nearly 30 to 40% chances of rendering this young patient infertile. Also, Ewing sarcoma.
इस पेशेंट को आपने भेजा क्या इनफर्टिलिटी?
Yes, sir. Yes.
डिपार्टमेंट ऑफ रिप्रोडक्टिव.
Nearly 30 to 40% chances of rendering this young patient infertile, and Ewing sarcoma per se being having very high rates of cure. This patient was counseled regarding fertility preservation, but the same was refused by the parents in view of cost constraints. So after giving written consent, the patient received 5 cycles alternating VAC-IE every 3 weeks. The VAC comprises of vincristine 1.5 mg per meter square. The dose is usually capped at 2 mg in view of the dose-dependent neurotoxicity caused by vincristine. Adriamycin at the dose of 75 mg per meter square. Cyclophosphamide 1200 mg per meter square. IE comprises of ifosfamide 1800 mg per meter square day 1 to 5 along with mesna. Etoposide 100 mg per meter square, again day 1 to day 5. Patient was monitored for chemotherapy related adverse effects on each visit. After completing 5 cycles of this therapy, MRI pelvis was advised for response assessment, and it was suggestive of partial response to therapy as it showed more than 30% reduction in the size of the primary lesion. To discuss this MRI in detail, I would like to call upon Dr. Diksha Alhawat from the Department of Radiology. Thank you.
So after 5 cycles of chemotherapy, MRI pelvis was performed. Here we have the stir sequences of the MRI in the coronal plane, where we can see the normal pubis bone on the right side, and compared to this, the left pubis bone appears enlarged with periosteal reaction and soft tissue. Here we can see an altered signal intensity lesion in the supraacetabular aspect, and with the soft tissue component extending medially along the acetabulum and ischium, and the soft tissue component extending laterally along the lateral wall of the hip bone. Here we have the T1 sequence in MRI, where the lesion gives hypointense signal in the same locations. Here we have stir sequence in the axial plane, where we can see areas of altered signal intensity with periosseous soft tissue. This is an axial cut above the level of the acetabular roof, where we can see the soft tissue and altered signal intensity here, and the same thing can be seen here. Here we can see the normal sciatic nerve on the right side, and this is the sciatic nerve on the left side, where the soft tissue can be seen abutting it, however no significant invasion can be seen. In these set of images, we can see that the entire acetabulum is involved with the subchondral extension of the lesion. However, no articular defect or intra-articular extension could be seen. So in the pre-chemotherapy MRI, the lesion measured 15.5 by 10.4 centimeters, and in the post-chemotherapy MRI, it measured 11 by 5.8 centimeters, showing response to chemotherapy. Now I would like to invite Dr. Akshay to further continue with the case.
Thank you, Dr. Diksha. Good morning to all the dignitaries present here, respective chairman, sir, and my dear colleagues. I, Dr. Akshay, third year resident of orthopedics, here to discuss the further management. So after post neoadjuvant chemotherapy, the size of the tumor is reduced around 40% with involvement of iliacus muscle and the gluteus minimus along with ischium, ilium and pubis. The challenges that came in our way were the patient is a young female with a fertile age group, and the tumor is also located near vital organs which are radiosensitive, and the surgical resection is also difficult due to the close proximity of the neurovascular structure. Now the main question is how to approach this type of complicated case. So we have two options available with us. The first one is radiotherapy, but as we know that local radiotherapy is not considered in our case because it can cause radiation-induced destruction to ovarian follicles, which can lead to infertility, also hormonal disbalance and premature menopause, and also it has bowel and bladder side effects. Second option with us was surgical resection of tumor, either by limb salvage surgery, which can be a tumor prosthesis, or extracorporeal radiation therapy, or by amputation. Yes, sir? Yes, sir, it can cause the avascular necrosis.
You are giving the radiation there itself, rather than going to vital organs. You have already damaged vital organs, especially the ovary, by giving the chemotherapy.
Yes, sir. As we know that amputation is a very debilitating procedure and has a major psychological impact on the patient. So nowadays we don't prefer amputation until and unless it is indicated. Some indications of amputations are if we are not able to achieve a negative margin through less radical approach, or limb with poor baseline function, if there is any local recurrence, or if involvement of neurovascular structure. Now talking about the limb salvage procedure, we have two modalities with us. The first one is prosthesis, which can be a customized or a usual one, on which as we can see in this picture that the implant, this is a prosthesis, and in this picture we can see that the implant is placed over ilium, replacing the periacetabular and the rama area. The second modality with us is the extracorporeal radiotherapy. We are continuously talking about the ECRT. I would like to take your attention towards it. So basically ECRT is surgical removal of the tumor bearing bone, after which the tumor bone is irradiated outside the body, and after irradiated, the sterilized bone is again reimplanted back into the patient's body. Now we have to decide whether to choose prosthesis or ECRT for this patient. Now take a look over pros and cons of both the techniques. So in ECRT there is bone preservation and the risk of infection is also less as compared to prosthesis, and the ECRT is a long lasting, and but the cons of the ECRT is the structure strength is weaker and delayed, and the risk of fracture is also more as compared to prosthesis. So after knowing all the pros and cons and taking the age of the patient and all the other parameters in consideration, we decided to go for ECRT. It is a multidisciplinary approach, so surgical planning has to include all the following departments. The main question is why the pelvic surgery is always challenging. As we already discussed, that the challenging part were the neurovascular structure like femoral nerve, obturator nerve, and the external iliac arteries and veins, which make it more challenging for us. There are different types of pelvic resection which are classified by Anneking and Dunham. In the type 1 resection, the resection is of the iliac wing, as we can see in this picture. In type 2, the resection is of periacetabular area. In type 3, the resection is of pubic rami, and type 4, there is resection of the sacrum. In a case, the tumor was involving the ilium, the paracetabular area, ischium, and both the pubic rami. So it consists of zone 1 plus 2 plus 3, that is almost the entire hemipelvis. Now the intraoperative step is to first do soft tissue dissection, then resect the bone tumor, after which we have sent the frozen section and the bone for ECRT, and then reimplant the bone. The first step is soft tissue dissection. The patient is taken in the floppy lateral position. This is the cranial end of the patient, this is the caudal, this is the medial end, this is the lateral part of the thigh. So the T-shaped incision was given. The first incision began at the pubic symphysis and continued over the inguinal ligament and ran posteriorly along the superior margin of the iliac crest to end over the sacroiliac joint. The second incision was a vertical one, passing through just posterior to the greater trochanter and extending to the thigh. All the muscular and ligamentous attachment were detached and the peritoneum was displaced medially. All the neurovascular structures isolated and protected. However, obturator nerve and vessels were passing through obturator foramen, so we have to divide and resect it. All the muscles were preserved except tumor involving muscle, that is iliacus and gluteus minimus, which were resected. In step 2, the wide local excision of tumor was done with tumor-free margins. The bony cuts taken as depicted in the picture. The SI joint was spared and the pubic symphysis was separated using a ghillie saw, after which all the soft tissue which was removed from the tumor bone. After taking out the tumor, frozen section was sent from 6 different sites, which includes the medullary cavity of the leftover ilium, the psoas major muscle, the gluteus maximus and medius muscle, the joint capsule, and the acetabular labrum, which were found to be tumor-free. After that, the excised bone was sent for ECRT. Now I would like to request Dr. Diksha from the Department of the Radiological Oncology to tell us more about the ECRT procedure.
Chairperson, dignitaries, and my dear colleagues. Myself, Dr. Diksha Shrimali, second year MD resident from the Department of Radiation Oncology. I'm here to give an insight about the procedure ECRT, that is extracorporeal radiotherapy. So ECRT is basically consists of 3 steps. First, the resection of the tumor bone. Which is done by the orthopedic department. And the first ECRT was done by Spira and Lubin in the year 1985. This is the irradiation of the autogenous tumor bone. So after the surgical resection of the bone segment, the bone segment was sent to radiation oncology department for the irradiation. So after that, the bone segment was brought to the radiation department. Then the bone segment was kept on the treatment couch. This is the treatment couch where the bone segment was kept. That was covered by the water plank, and water packets was covered to give the tissue equivalence. After that, the high dose radiation was given, which was around 50 to 300, that is a prescribed dose, and 2 parallel opposing AP fields were used. Then after that, the radiation was given, and the time taken overall was 40 minutes from the operation theatre to ECRT procedure and back to the OT. Thank you. Now I would like to call Dr. Akshay to further.
Thank you, Dr. Diksha. So these are the pictures. This is the pre-ECRT picture, and this is the post-ECRT picture of the tumor bone. Now the biggest challenge for us was the reimplantation. So for reimplantation, we have to put back the irradiated bone to its normal anatomical position, for which we have to do the anterior and the posterior bony reconstruction. So in the X-ray, the SI joint part is the posterior part and the pubic symphysis part is the anterior part. So for posterior reconstruction, we use these 2 reconstructive plates across the SI joint, and for the anterior reconstruction, we used a long curved reconstruction plate across pubic symphysis, which provide the stability to the pubic symphysis. The hip capsule reconstruction was done by Prolene mesh and the Ethibond suture, and all the muscle and ligaments reattached to the anatomical position using Ethibond 50 suture. These are the inlet and outlet views in which we can appreciate that the pubic symphysis and the SI joint are fixed to their anatomical position and there is no anterior, posterior or vertical translation of pelvis. The post-operative management and rehabilitation for this patient is on week 1, the patient was allowed for side sitting and rehabilitation exercises was started. On week 3, the suture removal was done and adjuvant chemotherapy was started. Week 18, the patient was allowed for partial weight bearing and on the week 24, the full weight bearing walk was allowed. The patient was followed up every 4 weeks for the first 6 months, every 3 months for 1 year and every 6 months till now. Clinical examination and the relevant investigations like chest X-ray for checking the metastasis and the part-specific X-ray was done at every follow-up. Patient was then referred back to the Department of Oncology for the adjuvant chemotherapy. As per the standard protocol, she completed all the 12 cycles of the adjuvant chemotherapy with alternating VAC-IE every 3 weeks and the patient was monitored for chemo-related adverse effect. This is the recent X-ray of the patient, follow-up X-ray after 4 years, in which we can see that the fracture is, the union is achieved and the hip is completely stable. There is no sign of AVN. The joint space is maintained and there is no sign of arthritis of left hip. This is the outcome of the patient after 4 years. In the first picture, we can see that the patient is very comfortable in the cross-leg position. In this video, the patient is walking very comfortably, and in the video, the third video, we can see that the patient is doing squats very easily. This is a video of dancing the patient and patient is really comfortable in this. Now I would like to invite Dr. Sandeep Yadav sir to enlighten us more about this.
Very good morning, respected dignitaries. The idea behind choosing this particular case was, as sir has discussed, that in adolescent or childhood age group, the second most common malignant bone tumor is Ewing sarcoma. But unfortunately, Ewing sarcoma of pelvis and spine, which consists the worst outcome. Other appendicular skeleton like tibia, femur and other long bones, we have a good outcome, good 5 years or 10-year survival rate with the Ewing sarcoma cases, but not with the pelvis and spine. The reason behind it is the complexity of the pelvis, the anatomy, and poor compartmentalization around the pelvis. That will lead to aggressive lesion that expand into the soft tissue as well as neurovascular structures, and sometimes may lead to metastasis also. So we have chosen this case as a CCR case, and in the literature we have reviewed the literature. There are various case series has been published, but on pelvis Ewing sarcoma the case series are limited, which includes hardly 10 to 15 cases, and especially on the ECRT very few cases has been reported so far, and consisting that our disease was involving both all three innominate bones, which includes ilium, ischium and pubis, and that was almost whole of the hemipelvis, and that is the most challenging part for us. So hardly 1 or 2 cases has been published in the literature with such extensive disease, and the lesion was more than 8 centimeter. Wherever the lesion was more than 8 centimeter, the prognosis is poor as mentioned in the literature. So I have discussed with my seniors, my colleagues and my professors before managing this case, and finally we have decided that the biological reconstruction is the best suitable option for this case, because patient was 14 years old at the time of presentation, and if we choose as sir has asked about the prosthesis, the lesion was the disease was involving ilium, ischium and pubis, all three innominate bones. So we have to use a saddle prosthesis or a customized prosthesis which should replace whole of the hemipelvis, and the fixation of that customized prosthesis is the biggest challenge, because we need to fix it either with the sacrum or with the spine. So the longevity of that prosthesis is very poor, complication rate of that prosthesis is very high, because that cannot stand for more than 6 years or 6 months or 1 year, because of the various muscle forces, so much of the load. That's why we have chosen for the biological reconstruction. considering that it took us 10 hours to perform this surgery, and I would like to thank onco surgery team, especially Dr. Diksha Yadav sir. He was there with me during the whole procedure. So probably, and this was the first case we have done in Rajasthan for the internal hemipelvectomy and ECRT and reimplantation, and fortunately and grateful that we are happy to provide excellent results after 4 years. So far we have done 10 cases of complex pelvic tumors, which includes this case, Ewing sarcoma, 4 cases of chondrosarcoma, 1 rare case myofibroblastic sarcoma, and 4 cases of giant cell tumor. I will share few of the cases. The X-ray showing is a GCT acetabulum. In this we have removed all of the tumor cell and reconstructed the acetabulum using the femoral head and neck, and then did the primary total hip replacement. This is very interesting case, chondrosarcoma right acetabulum. You can see the cauliflower-like growth over the anterior wall of the acetabulum and anterior column of the acetabulum. He was a young male of 32 years old with a yoga teacher. He came to us because he developed DVT in the same limb. And before proceeding for the surgery, we requested our intervention radiology and cardiology colleagues to put an IVC filter. They did it for us, and then we have resected all the tumor, and after removing the tumor, there is void on the anterior column of the acetabulum. We have reconstructed that column with the femoral head and neck, and fixed it with the recon plates, and finally did the total hip replacement. And you can see the wonderful outcome at 4 years. As I mentioned, he is a yoga teacher. He has sent this video from his home, doing all his routine activity after such a complex tumor case. He is able to do running, he is able to do all his routine activity. Again, very rare and one of the most important case is low-grade myofibroblastic sarcoma. Very few case reports has been published so far on this tumor, and we have resected it completely en masse. Type 1 and type 2 resection was done, and after resecting it, we did, as this tumor is chemo insensitive and radio insensitive tumor, so the surgical option is the only option. This patient came to me with the diagnosis of aneurysmal bone cyst, but when I see the MRI, I had a doubt, and I have discussed it with my radiology colleagues and advised for image guided biopsy, and eventually it turns out to be a low grade myofibroblastic sarcoma. It is very vascular thing, so before surgery we went for angioembolization, and very next day we did resection of the pelvis and mastoplasty, and patient is doing good, excellent outcome. Recently we have published this case as case report in one of the PubMed Index Journal of Orthopedic Case Report, because very few case has been published before, so we have published it recently. So in the end, I would like to thank, because the surgery went for 10 hours. So first of all, the anesthesia team, I am very grateful for the anesthesia team, medical oncology team for the medical management, staging and proper care of the patient in the post-operative period, surgical oncology team, most importantly Dr. Diksha Alhawat sir for being with me during the whole procedure, pathology for making the diagnosis, radiation oncology for definitely for ECRT procedure, radiology department and rehabilitation team, and the most important, the management of Mahatma Gandhi University, because they have provided us such a great platform and such a good infrastructure, so we can perform such complicated procedures. And finally, the CCR review committee for giving me opportunity to present this case in such a distinguished gathering. Because this is a rare case, and we were the first one in Rajasthan, so we have published it in various newspapers. Thank you so much.
Excellent surgery, excellent case.